Hello everyone. So I am sorry for the delay. I'll tell you I was here only, but I was not able to adjust the system according to the live classes. I hope my voice is audible and my screen is visible. If it is so, please let me know, everybody. If my voice is audible and my screen is visible, I'll be really glad if you can just let me know this. Hello everyone. So yeah, so this is something because I have been doing it on the company channel since long, but I have been doing it now for the first time on my own channel. So right, today what we'll be doing is we'll be revising gynecology, only the gynecology. Most likely will take 1.5 to 2 hours, and we'll finish all the recent questions of last 4 years that have been asked. We will do all the important questions and related topics. We can't waste much of the time. We don't have much time. All the Fmge related questions will be solved here, starting with menstrual cycle. Okay, chalo, starting with menstrual cycle. So if I have to make a menstrual cycle, I can solve many questions if I know what are the hormonal changes that are happening. Now be very careful when I'm telling you about these changes in the menstrual cycle. Okay, so menstrual cycle phase starts from day 0. Now day 0 is that phase where the menses start. Now you can divide a menstrual cycle into two phases. One is the follicular phase. Name signify follicular phase, matlab the follicles are forming. When the follicles start growing, that is the follicular phase. What is the hormone responsible for follicular phase? Question number 1. Follicle stimulating hormone. Very easy. The follicle stimulating hormone start rising slowly, and it is the one responsible for maturation of follicle. When your follicle grows to a one big size, one Graafian follicle, what happens is this FSH is rising. When the follicles start growing, they start secreting a very important hormone, and that hormone is, just a second, let me use a different color. Yeah. So follicle stimulating hormone is the one responsible for maturation of follicles. Now what happens is when these follicles are growing, they start secreting an important hormone, and that is the estradiol. Do you have to know this diagram and the hormones? Yes, you have to know this. So estradiol start rising. Estradiol is secreted by whom? Question number 2. Estradiol is secreted by the follicles. Okay? The follicles are secreting estradiol, and hence the estradiol levels are now rising. The rising estradiol levels result in suppression of the follicle stimulating hormone. So FSH is suppressed. Why it is suppressed? Because estradiol is very high. There is one other hormone that is suppressing the FSH, that is inhibin. Inhibin B is secreted from the follicles, and that suppress the FSH hormone. Why are we suppressing the FSH hormone? If we don't suppress the FSH hormone, too many follicles will grow. We want only one follicle to grow. That is why we have to keep it in limited amount. That is why FSH is inhibited, so that you get only one Graafian follicle. So in the follicular phase, initially FSH rise, then it suppress. What rises next is the estradiol. Now when the estradiol is persistently high, it results in something very important. The persistently high estradiol results in something called as LH surge. So which hormone is responsible for LH surge? Question number 2. Estradiol. Estradiol is responsible for LH surge. Now what happened when the LH surge is happening? Now starts the luteal phase. Now the luteal phase has started. Because of LH surge, what happened? Because of LH surge, the ovulation happens. So ovulation is because of the LH surge hormone. Now LH slowly keeps on falling. Now slowly it is falling. What happens? Now the corpus luteum is formed. So in luteal phase, estradiol is high, and in luteal phase, one very important hormone starts getting secreted, and that important hormone is progesterone. Okay? Suddenly a hormone which was low up till now, suddenly it becomes high. That is the progesterone. Estrogen, progesterone are high, secretory changes are happening, and as a result, finally when the LH finally falls, there is fall in both the estradiol and there is fall in both the progesterone, and when it falls, patient gets the menses and the next cycle start. Now, can I label each of these hormones if I need to? Can I label them? If somebody asks me, what is this blue peak? What is this? It is LS surge. It is the surge which is responsible for ovulation. What is this green hormone which is rising initially and then rising again in luteal phase? What is this green hormone? It is estradiol. Estradiol high levels are responsible for LS surge. What is this purple hormone which was initially very low and it rised in luteal phase only? This one is progesterone. So can I label each hormone? Yes. Can I tell which phase is responsible because of which hormone? Can I tell that? Yes. Follicle stimulating hormone is responsible for follicular phase. LS surge is responsible for ovulation. Who is responsible for LS surge? Estradiol levels. Who is responsible for secretory changes? Progesterone hormone. Menses happen because of progesterone withdrawal. Clear? Are we clear with this hormonal changes? Can we label each hormone? I'll show you the question next. Because of this follicular and luteal phase, what is happening in the endometrium? In endometrium, we have corresponding proliferative phase and secretory phase. Proliferative phase means just the thickness of the endometrium is increasing. Luteal phase matlab when the secretions start collecting. Now, very important thing what happens is jab bhi secretions, whenever you need secretions, there happens vacuolation. Vacuoles start developing. Vacuoles start developing in the cells. These are the vacuoles that are filled with secretions. What other thing happen is pseudo-cuffing. Pseudo-cuffing matlab aisa lagta hai, it seems as if the ducts are cuffed by some fluid. Some fluid is covering him. It is pseudo-cuffing. So these changes happen during secretory phases. Vacuolation and pseudo-cuffing. We'll see the questions related to them. Which of the following peak marked in the image is responsible for ovulation? Which peak is responsible for ovulation? The red one. This one. The LS surge. All of them are labeled 5. I think I should label 1, 2, 3, 4. The second peak is responsible for LS surge. What is the cause of LS surge? What is the cause of LS surge? There are many questions on physiology that should be clear to you. So, responsibility of LS surge is because of high estradiol. Okay? Which of the following is mechanism of action of inhibin? Naam hai, its name is inhibin. What will it inhibit? It inhibits FSH. Why it inhibits FSH? So that we get only one Graafian follicle. If we don't inhibit FSH, we will have so many Graafian follicles. We don't want that. Okay? So, function of inhibin is inhibition of FSH. Which phase of menstrual cycle shows vacuolation? Vacuoles. Vacuoles are the one that are filled with secretions. So that is a phase of, that is a feature of secretory phase. Done with these questions of physiology? So these many questions have been asked in the physiology. Coming to the puberty. Now puberty is a phase where a child enters into an adolescent phase, where a person who is not having that reproductive potential, when that enters into a person with reproductive potential, that is called as puberty. Let me have my tea. Yeah. If there is any doubt, let me know. I'll make sure I'll put PDF also here. That also I have to learn how will I be putting PDF in my channel, but I'll definitely put the PDF afterwards. It's my request, read the PDF today only or tomorrow. Don't try to read the PDF of my revision after 3 to 4 days. Then it will be of absolutely no use. Okay? Chalo. Puberty and sequence. Can anybody tell me at approximately what age the puberty starts? Puberty starts at approximately 11 years. Approximately. What is the first phase of puberty? Increased growth. Not growth spurt. Increased growth is the first sign of pubertal changes. But the first recognizable sign, you can't see that sign. When the bone length is increasing, you can't see it. First recognizable sign is thelarchy. Thelarchy matlab breast development. That is the first visible sign of puberty. So first visible sign of puberty is thelarchy. After thelarchy, they have pubarchy. Pubarchy is increased in the pubic and axillary hair. You might feel I'm speaking little fast, but I have to finish a lot. So we will just keep it a very tight scheduled class. After thelarchy, we have pubarchy, which is pubarchy means pubic and axillary hair. And after that, there is a growth spurt. Suddenly, the height increase. Now there is a growth spurt, and after that is menarche. Menarche matlab the first menses. So you might have seen that notion that if the girl get menses, now her height doesn't increase much. Why? Because growth spurt has already happened. Menarche se pehle growth spurt has happened already, and when the menarche comes, growth spurt has ended. ठीक है? Remember the sequence, and now remember the hormones responsible. Who is responsible for the breast development? Which hormone is responsible for breast development? Estrogen, especially estradiol, that is responsible for thelarchy. Who is responsible for pubarchy? For pubic and axillary hair. See, hair growth is not a feature of estrogen. Estrogen doesn't result in hair growth. So hair growth is because of the androgens. अब भाई androgens कहाँ से आएंगे? Where does a female get androgens from? Adrenal androgens. So hair growth is a feature of androgens, be it axillary and pubic hair. That is also function of adrenal androgens. ठीक है? Growth spurt happens because of the growth hormone and insulin-like growth factor. They are responsible for growth spurt. And menarche is, we have just read, menarche is a function of combination of so many hormones, especially estrogen and progesterone. So these are the hormones responsible for pubertal changes, and this is the sequence. ठीक है? Okay? A mother comes with a 12-year-old girl. Girl has developed breast, thelarchy आ गया, pubic hair, pubarchy आ गया. Mother wants to know which sign of puberty will come next. So after thelarchy and pubarchy, what will come next? Growth spurt. She will have a growth spurt followed by menarche. So remember, in this puberty chapter, remember only the sequence and remember the hormone responsible. ठीक है? Sequence and the hormone responsible. Okay? Now comes amenorrhea. Now comes the definitions. What is amenorrhea of primary and secondary? Primary amenorrhea. What is the definition of primary amenorrhea? Please be very clear in it. Do not use old definition. There are two age groups. A girl who does not develop breast and no menses. Obviously, if there has been no breast, then obviously menses will also not come. It is a sequence. So no breast, no menses even after age of 13 years. First age group. Suppose a girl develops breast are developed. You give her a leverage. You give her extra 2 years. She develops breast but no menses. Menses have not come till 15 years. So in case breast has developed, you wait for 2 more years to menses to come. In case menses doesn't come even after 2 years of breast development, yani 15 years pe, then that is primary amenorrhea. Anybody who has no breast, no menses, then you will evaluate her at age of 13 years. ठीक है? So 13, 15. बहुत जगह पे written 14, 16 लिखा है. This is the older one. Now it is 13, 15. Since puberty has started coming at earlier age because of good diet, now the age is shifted to 13, 15. So no breast, no menses even at age of 13 years. Breast present but no menses at age of 15 years. These are the two definitions of primary amenorrhea. ठीक है? Now what are the causes? Let's finish causes here only. There are 3 segments. There can be a central cause, there can be ovarian, and there can be a peripheral uterine cause. Whenever central cause is there for primary amenorrhea, central cause, question will give you low FSH and LH. FSH and LH will always be low. Low means less than 5 international units. Please be very careful. Okay? So when I'm telling you, because questions are asked on these, you will be given a scenario of primary amenorrhea, FSH, LH value will be given to you and you will be asked the pathology. Okay? Diagnosis is something that should be known to you as an FMG graduate. कि diagnose कैसे करना है? Not the management, but at least diagnosis. So whenever there is a central cause, FSH, LH are always low. ठीक है. First thing, what are the causes? So first important cause is physiological delay. That there is no problem, it is just that it is how it runs in the family. It's just a physiological delay. Another very important cause is Kallmann syndrome. Whenever question will give you Kallmann syndrome, question will always give you anosmia. In Kallmann syndrome, there is primary amenorrhea along with anosmia. So question will give you anosmia. Along with that, if I am talking about primary amenorrhea, then there can be some kind of tumor. ठीक है. अनलाइकली कि प्राइमरी एमेनोरिया 13 ईयर्स की गर्ल में देर इज अ ट्यूमर, वेरी अनलाइकली. द इंपॉर्टेंट कॉजेज आर फिजियोलॉजिकल डिले एंड कैलमैन सिंड्रोम. ओवेरियन कॉजेज, whenever it is ovary which is causing amenorrhea, the problem is with the reproductive organ. FSH and LH will be high मतलब more than 20 international units. ठीक है. So if FSH LH are high, it is ovarian problem. If FSH LH are low, it is central problem. In ovary, what are the causes? Dysgenesis. Primary है ना, she has never faced amenorrhea. Dysgenesis मतलब gonads बने ही नहीं हैं. Gonads have not formed. Why gonads have not formed? What is the reason of dysgenesis? Turner syndrome. Very, very important. Turner syndrome. A girl is X0, that is why her gonads have not formed. ठीक है. Again, gonads have not formed. Gonadal dysgenesis है. But she is not X0. She is normal XX. Still, because of some micro deletions, some small chromatid problems, the gonads have not formed. We call it pure gonadal dysgenesis. Pure gonadal dysgenesis matlab the chromosomal makeup is normal. Still gonads have not formed. XY. If it is XY gonadal dysgenesis, we call it Swyer syndrome. Remember these three. Turner syndrome, pure gonadal dysgenesis and Swyer syndrome. They all are the genetic problem where gonads don't form. Since gonads don't form, that is why FSH LH are very high. ठीक है. Okay. One very important thing about Turner's and Swyer syndrome. In Turner syndrome, she externally has genitalia of female. All of them have genitalia like female. That is why they have come to gynecological OPD. External genitalia is female in all of them. But Turner syndrome में there is no Y chromosome. There is no Y chromosome, so uterus and vagina are present. ठीक है. Uterus vagina does not need X chromosome. Uterus vagina just need absence of Y chromosome. There is Y chromosome absent, uterus vagina have formed. In Swyer syndrome, uterus and vagina are absent. ठीक है. Uterus vagina absent. Why? Because there is a Y chromosome. ठीक है. Going right. There is a Y chromosome, gonadal dysgenesis. I'm so sorry here. I've just got confused. No. In all of these three pathologies, I'm so sorry, correct it. In all three pathologies, uterus and vagina are present. Why uterus vagina are present? Because even though there is a Y chromosome here, it is dysgenetic. It is non-functional. It is non-functional, so it can't stop uterus and vagina from forming. So Turner syndrome patient has uterus and vagina, but the ovaries are non-functional. The ovaries do not function. ठीक है. Then hence they do not have any reproductive potential. Hence they do not get menses. Okay. But just remember that whenever it's a central cause, FSH LH are low. Whenever it's an ovarian cause, FSH LH are very high. What are the ovarian causes? Most important, Turner syndrome. Is Turner syndrome the most common cause of primary amenorrhea? Yes. Turner syndrome is the most common cause of primary amenorrhea. What are the other causes? XX, pure gonadal dysgenesis. XY, Swyer syndrome. Externally, they all have female genitalia. Internally, they have uterus vagina, but their gonads are non-functional. Gonads don't function. What if there is a problem of outflow tract? What if there is problem in this uterus and vagina? Since uterus and vagina don't produce hormone, the hormones here are normal. Hormones don't change whenever the cause is uterine. ठीक है, what can be the uterine causes for primary amenorrhea? There is a blockage. Menses are coming but not coming out. Imperforate hymen. Transverse vaginal septum. What else? Uterus have, vagina have not formed. Just like there was ovarian dysgenesis, it is Mullerian dysgenesis. Due to some chromosomal problem, the Mullerian duct has not formed. Also called as MRKH. I'll write down here. Also called as MRKH. Hormone levels, normal. So remember the hormonal changes in each of them. Talking about Turner syndrome, it is the most common cause for primary amenorrhea. It is an X0 individual. It is the most common cause of primary amenorrhea. And what about FSH-LH? FSH and LH are very high in this patient. Also, Turner syndrome somehow presents with various other stigmata. When it is present, there are many other physical features which are there. Starting from above, the person has a low hairline. अगर आप ऊपर से शुरू करोगे, low hairline. ठीक है? Then what is there? Shield chest. Shield chest मतलब the nipples are wide apart. Shield chest. Then webbed neck. There is a webbed neck. These are the features that are present in Turner syndrome. There is cardiovascular anomalies. Then increased carrying. Can you see the shape of the hand like this? ऐसे. Hand is like this. It is called as increased carrying angle. Carrying angle is increased. ठीक है? Then short fourth metacarpal. These are the features. They have no significance, but these physical features, if given in question, it is Turner syndrome. They are not associated with any other syndrome. Now see the question. A young girl come to OPD with primary amenorrhea. Her breast not developed. She has a short stature. Certain physical manifestations like short neck, increased carrying angle. What is the pathology? Turner syndrome are also short statured. ठीक है? Swyer syndrome and XX pure gonadal dysgenesis are not short stature. Turner syndrome people are short stature. So what is it? It is Turner syndrome. And what will be the karyotype in Turner syndrome? X0. ठीक है? Okay, good. In last question, what will be her hormonal levels? What are her hormonal levels in last question? In this last question of Turner syndrome, what will be her hormonal levels? Please tell me. Correct. FSH, LH both high. Whenever there is ovarian problem, Turner syndrome में problem क्या है? Ovaries are not forming. Gonadal dysgenesis. Gonads are not forming. Whenever gonads are not forming, FSH, LH will rise. Why? Because there is no negative inhibition. There is no negative inhibition. That is why FSH, LH is very high. ठीक है? तो जब भी gonadal dysgenesis है, no, FSH, LH will be high. Okay, beta, not low. See this diagram. I just showed you. सेंट्रल कॉज में FSH-LH लो है, ओवेरियन कॉज में FSH-LH हाई है. ओवेरियन कॉज में क्या क्या आते हैं? टर्नर सिंड्रोम, प्योर गोनाडल डिसजेनेसिस, स्वायर सिंड्रोम. ये सब प्रॉब्लम्स ओवेरियन डिसजेनेसिस करती हैं. जब भी ओवरीज आर नॉट फॉर्म, FSH-LH राइज टू वेरी हाई लेवल्स. ठीक है? अ गर्ल कम्स विद प्राइमरी एमेनोरिया. she has been raised as a girl. Her breast is not developed. Uterus is absent. On karyotype, she is 46XY. क्या ये XY स्वायर सिंड्रोम हो सकता है? Can it be स्वायर सिंड्रोम? स्वायर सिंड्रोम में यूट्रस एंड वजाइना, आई टोल्ड यू, इज प्रेजेंट. ठीक है? क्योंकि Y क्रोमोजोम यूट्रस वजाइना को फॉर्म नहीं होने देता. बट स्वायर सिंड्रोम में देर इज XY डिसजेनेसिस. XY तो है, but it is gonads are dysgenetic, they are not functional, so this Y syndrome is not able to act. वो act ही नहीं कर पा रहा है. When it is not acting, uterus vagina will form. Then what is it? 46XY but uterus absent, breast not developed. What is this condition? It is 17 hydroxylase deficiency. This was a very rare question that was asked. ठीक है, very unexpected, but 17 hydroxylase deficiency, it is an enzyme that converts androgen into its active form, and when it is deficient, though it is a male but it looks like a female. एंड्रोजन इनसेंसिटिविटी सिंड्रोम क्यों नहीं है? एंड्रोजन इनसेंसिटिविटी में ब्रेस्ट डेवलप्ड होते हैं. अभी हम पढ़ेंगे, वी विल रीड एंड्रोजन इनसेंसिटिविटी. देयर द ब्रेस्ट इज डेवलप्ड. सो आई मस्ट टेल यू इट वॉज नॉट अ वेरी गुड क्वेश्चन, क्योंकि कुछ भी नहीं फिट हो रहा था. एंड्रोजन इनसेंसिटिविटी में ब्रेस्ट डेवलप्ड होते हैं. MRKH का पेशेंट XX होता है. MRKH मतलब मुलेरियन एजेनेसिस. इट्स एन XX गर्ल जहाँ पे मुलेरियन स्ट्रक्चर्स नहीं फॉर्म हुए. सो इट इज़ XX, ये भी हटा. स्वायर सिंड्रोम में यूट्रस प्रेजेंट होता है, वो भी गया. 17 हाइड्रोक्साइलेज इज द आंसर बाय एक्सक्लूजन. And if you read 17 hydroxylase, it's a rare disorder. I don't know why the question was asked. It's a rare disorder where because of this enzyme deficiency, this XY male is not able to express the active Y, active testosterone. And hence, the uterus, hence, though it is a male, it looks like female. Uterus absent, breast not developed, but external genitalia are like of female. ठीक है? Which of the following is not a feature of Turner? Not a feature. Webbed neck, it is a feature. Widely spaced nipples, it is a feature. Coarctation of aorta, it is there. Mental retardation, Turner syndrome are not mentally retarded. They may have a borderline IQ, they may have, but they are not mentally retarded. So Turner syndrome is not a mental problem. ठीक है? Turner syndrome ये हमने पढ़ लिया. Now that was about ovarian dysgenesis. Now little bit about outflow anomalies, or I can say Mullerian anomalies. Remember, whenever there will be Mullerian anomalies, your hormone levels will be normal. Since the hormone levels are normal, this girl will always have normal breast development. Breast will be developed. Why breast is developed? Because hormones are normal. So breast is always developed. ठीक है? So remember few features. Central cause है तो FSH and LH low है. Ovarian cause है तो FSH and LH high है. Outflow की प्रॉब्लम है, Mullerian प्रॉब्लम है तो हॉर्मोन्स नॉर्मल है. Since इसमें FSH LH लो है, ईस्ट्रोजन लेवल्स लो है. इसमें ओवेरियन डिसजेनेसिस है, ovaries have not formed, so estrogen is very low, and hence in these pathologies breast not developed. Breast is not developed. But when it is Mullerian problem, hormones are normal, this girl has breast developed. So जब भी क्वेश्चन आपको देगा breast developed, सीधा think about Mullerian anomalies. Whenever question gives you breast development is normal, straight away think about Mullerian anomalies. ठीक है? Mullerian anomalies में क्या हो सकता है? या तो there is a blockage, there is a genetic blockage, or Mullerian tract is missing altogether. It is not there. It is missing. When it is missing, we call it MRKH, Mayer-Rokitansky-Kuster-Hauser syndrome, also called as Mullerian agenesis. So Mullerian agenesis is a girl. She is an XX girl. It's just that her uterus has not formed. That's it. But her hormones are normal. That is why the secondary sexual characters are present. That is why the breasts are developed. Her breasts are developed. Talking about blockages, there can be two kinds of blockages. One is imperforate hymen and one other one is transverse vaginal septum. Imperforate hymen is a thin membrane, so it is a bulging bluish membrane. Bulging bluish membrane. Vaginal septum is a thick muscle, so it is non-bulging and it is pink. Vagina, can you see vagina here? No vagina visible. Absolutely no vaginal opening seen. Here, small vagina can be seen. Can I see a small vagina? Yes, small vagina seen. So these are the two blockages. It is just the blockage, that is why I am repeating again. hormones will be normal, and that is why the breast development will be normal. Hold on. Hello. हेलो. हाँ 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 है, भेज दो. ठीक है. Now see the question. So there have been many questions on diagnosis of primary amenorrhea. 14-year-old girl present with cyclical pain. Why there is a cyclical pain? Because हर महीने menses are coming, but it is not coming out. It is hidden. That is why we call it cryptomenorrhea. क्योंकि menses आ रहे हैं, they are collecting in uterus, but they are not coming out. So there is a cyclical pain. Cyclical pain very characteristically tell you there is obstruction. Very characteristically. So cyclical pain है, hypogastric lump है. There is no menarche yet. PV में you see a bluish. Can you see swelling? Just like I told you, a bulge, bluish bulge. Is it a septum? It's imperforate hymen. It's a bluish bulge, and cyclical pain characteristically show you the obstruction. 17-year-old female present with primary amenorrhea, but she gets abdominal pain every month. Again obstruction. On examination, she has normal development of secondary sexual characters. Obviously, there is a lump which is uterus. On parting the labia, bluish bulge. तो क्या diagnosis है? Bluish bulge, imperforate hymen. Consider the diagnosis and the management. When it is a thin membrane, the simple answer is cruciate incision. You will not do hysterectomy in 17-year-old girl. Excision of septum, it is not septum. It is a imperforate hymen. Why will I excise the septum? Dissection and vaginoplasty, no. It is a very thin membrane. Just make a cruciate. Cruciate is like this. Just make a cruciate incision. Open it up. That's the treatment. Transvaginal septum का क्या treatment है? What is the treatment for transvaginal septum? Excision of the septum. ठीक है? A mother brought her 16-year-old daughter to hospital with again primary amenorrhea. On evaluation, her axillary and pubic hair were present. Secondary sexual characters are normal. Secondary sexual characters normal है, मतलब we are dealing with something outflow tract की problem है. LH FSH are normal. It means ना ही central problem है ना ही ovarian. It is not ovarian, not central. Ultrasound show absence of uterus. Uterus is absent. ठीक है. टर्नर सिंड्रोम नहीं हो सकता. टर्नर सिंड्रोम में ब्रेस्ट आर नॉट डेवलप्ड, FSH LH आर हाई. इन्होंने क्या लिखा है? LH FSH आर नॉर्मल. नहीं है. देन स्वायर सिंड्रोम में अगेन स्वायर सिंड्रोम इज एन ओवेरियन प्रॉब्लम. LH FSH आर हाई. ये भी नहीं है. नाउ इज इट MRKH और एंड्रोजन insensitivity? In androgen insensitivity, because the tissues are insensitive to androgen, name signify it is insensitive. So pubic and axillary hair, I told you, hair development is the feature of androgens. If it is androgen insensitivity, your tissue is insensitive, will pubic and axillary hair develop? No. Here they were developed, so it is MRKH. ठीक है? Why it is MRKH? Because when the tissue is insensitive to androgen, pubic and axillary hair will not develop. In both of them, the uterus is absent. They look very similar. The uterus is absent in both of them. But pubic and axillary hair are present here. It is not present here. It is an XX girl. It is an XY boy who looks like a girl. ठीक है? A woman has been diagnosed with this uterine anomaly. It happens due to fusion of which duct? Problem in fusion of, this is what? This is uterus. Most likely it is uterine septum. So which duct forms uterus? We have been talking again and again. Mullerian agenesis, Mullerian agenesis. Mullerian ducts form the uterus. Mullerian ducts are also called as paramesonephric duct. Mesonephric duct, Wolffian duct form the male genitalia. So mesonephric duct के साथ में the one adjacent to male mesonephric duct is paramesonephric duct. Paramesonephric duct is also called as Mullerian duct. So it is the fusion of Mullerian duct which has not happened, resulting in this anomaly. ठीक है? Wolffian duct. देखो how I used to remember Wolffian duct. Wolf. So I used to remember it is for males. Mullerian duct how I used to remember, Mullerian duct में एक U आता है for uterus, दो L आते हैं for tubes. So I used to remember it is U with tubes ऐसे. So Mullerian duct is for uterus, Wolffian duct is for males. So it is paramesonephric duct. So this was all about primary amenorrhea. I hope that was clear about primary amenorrhea. Coming to secondary amenorrhea. Secondary amenorrhea में there have been questions only from PCOS. कुछ questions Asherman syndrome से भी आए हैं, but they are so fond of PCOS. PCOS का diagnosis, PCOS का hormonal change, PCOS का treatment. They have asked everything about it. ठीक है? So we'll study a little about secondary amenorrhea, then we'll switch to PCOS. Secondary amenorrhea, what is the definition? She used to menstruate previously. Now she is not menstruating since last 6 months. If she has regular cycles, she is not menstruating since 6 months. If she has irregular cycles, then अगर irregular cycles है, she is not menstruating since last 3 cycles. This is the definition. जिसको regular cycles आते हैं, last 6 months से if her menses are not there, she is secondary amenorrhea. Suppose somebody has prolonged cycles, then in case of she misses her last 3 cycles, we call it secondary amenorrhea. ठीक है? Clear? Now secondary amenorrhea definition we have done. Again the same causes. Central ovarian outflow, same hormonal changes. जब भी central cause होगा, now here the cause is not genetic, cause will be acquired. But जब भी central cause होगा, FSH and LH हमेशा low होंगे. जब भी ओवेरियन कॉज होगा, FSH एंड LH हमेशा हाई होंगे. जब भी प्रॉब्लम यूट्रस की है, वेन एवर द प्रॉब्लम इज ऑफ यूट्रस, देन FSH एंड LH आर नॉर्मल. ठीक है? नाउ सेंट्रल कॉजेज, व्हाट आर द सेंट्रल कॉजेज दैट कैन लीड टू सेकेंडरी एमेनोरिया? स्ट्रेस, डाइट चेंज, बट वेरी इंपॉर्टेंट, अ central tumor. So it can be a tumor in the pituitary, among which the most common is prolactinoma, a prolactin secreting tumor. So a prolactin secreting tumor will result in falling FSH-LH, as a result secondary amenorrhea. There can also be degeneration of pituitary gland, Sheehan syndrome. Sheehan syndrome that happens after delivery. So if a scenario is given, a patient has just delivered, there was significant PPH and now she is not menstruating. Delivery के बाद there was significant PPH, now she is not menstruating. It is Sheehan syndrome. Her FSH-LH will be low. ठीक है? What are the ovarian causes? Premature ovarian failure. Ovarian failure at less than 40 years को हम premature कहते हैं. Ovaries have to fail. Menopause has to come. But when it comes before 40 years, we call it premature. Here FSH-LH are very high. Very high मतलब more than 20. And as a result, patient stops having menses. One of the most common cause, in fact I'll call you the most common cause of secondary amenorrhea is actually pregnancy. Pregnancy is the most common cause. So whenever you get a patient of secondary amenorrhea, the first thing you do is UPT. But the most common gynecological cause is PCOS. PCOS means ovary is not failing. Premature ovarian failure. Ovary is failing. PCOS is anovulation. Ovary is not failing. It is just not ovulating. ठीक है? So here FSH-LH are not very high. Here hormonal changes are very different. We will discuss PCOS in detail. In PCOS में hormonal changes are different from failure. Failure मतलब fail हो जाना. That is why FSH-LH are high. PCOS में it is not ovulating. Due to high androgen levels, due to insulin resistance, it is not ovulating. We will see what hormonal changes happen. What can happen in outflow tract? Asherman syndrome. Asherman syndrome matlab there is serious injury to the endometrium, scars have formed and that is why she stops bleeding. So if we talk about Asherman syndrome, there is injury to the endometrium basalis. When your basalis is injured, it never heals. It never heals. Again, it results in scar formation. And when it is scarred, there will be no menses. What is the cause of Asherman syndrome? Vigorous curettage. tuberculosis. Remember, your hormones will be normal. So question gives you a history of vigorous curettage, hormones normal, Asherman syndrome. How do you diagnose Asherman? You can see it on as such ultrasound also. Can you see the ultrasound image like this? There is filling defect. This is ultrasound of Asherman. Can you see the scar tissue? How scarred it is? This is ultrasound. This is HSG. So you can see the Asherman on HSG also. In HSG में there will be filling defects. But the diagnostic for Asherman is hysteroscopy. Hysteroscopy, can you see the scar? How badly scarred and stuck it is? Hysteroscopy is diagnostic. Okay? See the images both in hysteroscopy and HSG. You can get image at both the places. Okay? This was Asherman. PCOS. Bhaiya, PCOS pe they have asked so many questions about everything. What is PCOS? It is the most common cause of anovulation. It is the most common cause of abnormal uterine bleeding. Okay? There are diagnostic criteria where you need three things. Hyperandrogenism. High androgen levels clinically. Clinically hyperandrogenism. Clinically कैसे पता चलेगा? Increased hair growth, acne. Then polycystic ovary. And then clinical or biochemical hyperandrogenism. Androgen levels are high either clinically or you did the blood test. Blood test भी करते हैं. Suppose किसी को somebody does not have increased hair growth, then you do the blood test. And blood test showing high testosterone, that is also PCOS. So clinical या फिर biochemical hyperandrogenism. ठीक है? Then polycystic ovaries and then anovulation. Anovulation कैसे पता चलेगा? She has irregular menses. Either irregular menses है या फिर she has secondary amenorrhea जो हम पढ़ रहे हैं. If she has no ovulation, how will she menstruate? She will not menstruate, or she will menstruate after 3, 4 months. So what are the three things? Clinical or biochemical high androgen levels. Polycystic ovary. Polycystic ovary मतलब बहुत सारे छोटे छोटे follicles, multiple small follicles. बस ये term याद रखो, multiple small. So when it is multiple small, there are more than 12 in number. Very small, 2 to 9 mm. They are always less than 10 mm. And ovarian volume is more. Because इतने सारे follicles filled हैं. There are so many follicles filled in it. So ovary become heavy. So multiple small follicles is polycystic ovary. And last is anovulation. Okay? There is also hair and syndrome seen in PCOS. PCOS is a problem where there is also insulin resistance. It coexists. So insulin resistance की वजह से acanthosis nigricans होता है, which is thick velvety skin on the folds. Thick velvety skin दिख रहा है nape of neck पे, thigh पे, axilla पे. So this is a feature of insulin resistance. So hair and syndrome is seen in PCOS. Hair and syndrome मतलब hyperandrogenism, insulin resistance and acanthosis nigricans. When all these three are present, very characteristic of PCOS. Androgen levels भी high है, insulin resistance भी है, acanthosis nigricans है. It is very indicative of PCOS. ठीक है? What is the hormonal changes in PCOS? Yes, hormonal changes. What is happening is, because of insulin resistance and because of the genetic changes, suddenly the LH levels are high. They are constantly at high level. There is no LH surge. So LH are constantly high. Because of high LH, ovaries start secreting high androgens. So androgen levels are high. This androgen goes in the periphery and form estrone. So estrone is high. But what happens? FSH gets suppressed. FSH is low. Estradiol is low. जो main estrogen है estradiol, that is low. Please be very clear. इस पे बहुत सारे questions आए हुए हैं. LH high है, FSH low है. एंड्रोजन्स हाई है बिकॉज ऑफ विच ईस्ट्रोन इज हाई, ईस्ट्रोन इज E1, पर FSH इज लो, दैट इज वाई ईस्ट्राडायोल इज ऑल्सो लो. तो क्या क्या हाई हो गया, LH इज हाई, ईस्ट्रोन इज हाई, एंड्रोजन लेवल्स आर हाई. एंड लो क्या क्या है, FSH इज लो, ईस्ट्राडायोल इज लो. ठीक है. A girl present with irregular periods. She has acne and she has facial hair growth. Ultrasound show multiple follicles. Obviously, it is a case of PCOS. Which of the following would be increased? Testosterone is increased? Yes. FSH levels are reduced. FSH-LH ratio reduced. FSH low है, LH high है, ratio reduced. Sex hormone binding globulins. ये sex hormone binding globulins are the one जो androgen को bind कर लेते हैं. So that androgen is not in free form. Females में sex hormone binding globulins level are high, तभी सारा androgen is bound and it can't act. PCOS में sex hormone binding globulin reduce हो जाता है, because of which वैसे भी testosterone is high, also we get lot of free testosterone. Testosterone वैसे भी high है and lot of free testosterone is circulating because this globulin which is produced by liver, it reduce. So what is increased? Testosterone. ठीक है. A woman underwent DNC followed by a missed abortion. UPT is negative. She has now amenorrhea. HSG shows this. What is this? Is it Sheehan syndrome? Sheehan is pituitary necrosis. It is Asherman syndrome. Can you see the filling defects? Dye is not getting filled because of scars. Which of the following investigation is performed in PCOS patient? Urine culture, sleep study, thyroid profile, या serum testosterone? Remember clinical or biochemical hyperandrogenism. Correct, testosterone. Very good. A nulliparous lady with BMI 23 present with hirsutism. Ultrasound shows this. Can you see ovaries with so many small follicles? Multiple small follicles. What is this? PCOS. A 35-year-old woman present with irregular cycles, hirsutism and acne. On examination, there is also acanthosis nigricans. Very clear. Lab investigation show elevated serum testosterone. They to are telling, this question is telling you diagnosis on face. Testosterone high hai, acanthosis nigricans hai. What is it? PCOS. Which of the following is decreased in PCOS? What is decreased in PCOS? Is LH decreased? No, LH is high. Testosterone? High. FSH? Decreased. Estrogen. Now they have not mentioned estradiol. Estradiol reduce होता है, but estrone high होता है. PCOS is a hyperestrogenic condition. उसमें estrone इतना high है, we call it hyperestrogenic. So what is reduced is FSH. Good. A patient suffering from hirsutism, ultrasound shows pearl of string appearance, like a necklace. Pearl of string. What is the diagnosis? Simple. So this is all they have asked about PCOS. The diagnosis, the hormonal changes. Now the treatment. Remember, PCOS is a genetic condition where there is insulin resistance. Okay? So the first thing that you do in a PCOS patient is always lifestyle management. Always. Kitna bhi weight ho, you always advise her lifestyle management. So the first step is lifestyle management. इसके बाद PCOS is treated according to the pathology, according to the symptom. What symptom she has, according to that the PCOS will be treated. If the problem is with menses, her menses are irregular, then the treatment of choice is OCPs. You give her monthly OCPs, her endometrium will keep on shedding and her menses will become regular. You can also give cyclical progesterone. If the problem is hyperandrogenism, the problem is acne, hair growth, that is the problem, then the treatment of choice is again OCPs. When you give OCPs, तो क्या होता है? Sex hormone binding globulin, which we discussed, वो बढ़ जाता है. And when it increase, it binds the androgen. So hyperandrogenism may be OCPs are the drug of choice. Other than that you can give anti-androgens also, but anti-androgens हमेशा बाद में चलाते हैं. They are always given once your OCPs don't work. उससे पहले नहीं देते. Anti-androgens are not given first hand. If the problem is infertility, why infertility? Because there is anovulation. Then you give ovulation induction drugs. What are the ovulation induction drugs? Clomiphene citrate, letrozole. These are the first choice. First choice are clomiphene citrate and letrozole. If they don't work, we give GnRH injections, gonadotropin injections. This is the second choice. Third choice, which पे बार बार क्वेश्चन आए हैं, वो है ड्रिलिंग. You drill holes in the ovary. When you drill hole in the ovary, you are trying to rupture the cyst, that multiple cyst you are trying to rupture. This is laparoscopic ovarian drilling. And last is IVF. So this is the management of infertility in a PCOS patient. Showing the laparoscopic procedure done in which of the following conditions? Can you see the holes being drilled? Where will you do it? Where will you drill holes and trying to rupture the follicles? The condition where follicles are too many. When there are too many follicles. In an ovarian tumor, will you drill holes or will you remove the tumor? PCOS. A girl comes to you with complaint of irregular periods, excessive hair growth. You know what you are dealing with. What is the first line of treatment? First line. OCPs are the treatment of choice for irregular periods also, for hair growth also. But their question is not drug of choice. Their question is first line treatment. Always lifestyle. Always lifestyle. सबसे पहले लाइफस्टाइल मेजरमेंट होता है, उसके बाद आते हैं मेडिकेशंस. ठीक है. Ovarian drilling procedure is done in PCOS. A female patient with history of abortion present with amenorrhea. Her serum evaluation shows FSH 7. Normal है. SCG is less than 5, मतलब pregnant नहीं है. What is the diagnosis? Is it PCOS? PCOS का कोई feature ही नहीं है. They have not given hair growth. They have not given acne. They have given history of abortion and hormones are normal. So what is the answer? Uterine Gynaecology. Abortion के बाद Gynaecology बन गए. That is why hormones are normal. Otherwise hormones are changed in PCOS, right? A young female has history of spontaneous abortion. Her FSH is 6. The following cause we have done it, Asherman. A patient being evaluated for amenorrhea. Her FSH LH are found to be high. What could be the probable reason? Her FSH LH are found to be high. If her FSH LH are high, means problem कहाँ से है? अगर FSH LH are high, problem is from where? Is it the center? Is it the ovary? Is it the uterus? When the FSH LH are high, problem is always the ovary. So why it is high? Low estrogen levels due to ovarian failure. High estrogen due to taking OCPs. High prolactin, uterine anomaly. Uterine anomaly में FSH LH थोड़ी high होगा. High prolactin levels, अगर prolactin secreting tumors हैं, तो FSH LH तो low होना चाहिए. It is ovarian failure. Whenever there is ovarian failure, estrogen is so low that FSH LH become high. There is no negative inhibition. As such, estrogen हमेशा FSH LH को दबा के रखता है. It always suppress FSH LH. It is called negative inhibition. But when negative inhibition is gone, FSH LH becomes very high. ठीक है? Clear? So this was secondary amenorrhea. Many questions on PCOS, few questions on Asherman syndrome. ठीक है? Now, how do you evaluate? जब भी आपके पास secondary amenorrhea की patient आती है, the first thing that you do not miss urine pregnancy test, because the most common cause is pregnancy. Always do secondary amenorrhea में, always do UPT. ठीक है? Okay? After UPT, now I want to know what system is involved. So what I do is, first thing I do is progesterone challenge test. इस पे question भी आया है आपका. Progesterone challenge test. I give progesterone for 10 days. And then I withdraw it. इसे कहते हैं progesterone withdraw कर लिया आपने. Artificially, but you withdraw the progesterone. Now after withdrawing, you want to see whether the menses come or not. Suppose menses come, menses आते हैं, it means the body has normal estrogen, normal uterus, is just that there was no progesterone. When you gave progesterone and withdraw it, patient started bleeding. So patient had no progesterone. Why patient was not having progesterone? Because she was not ovulating. Progesterone हमेशा ovulation के बाद बनता है. Remember, only corpus luteum form progesterone. She is not ovulating, that is why she doesn't have progesterone. When you gave progesterone, menses have come. So anovulation is the cause. PCOS, hypothyroidism, hyperprolactinemia, all that cause anovulation. Suppose menses don't come. Ab menses have not come after giving progesterone. What do you give? You add estrogen. You give progesterone and you add estrogen. Suppose now menses have come. It means what was body lacking? Body was lacking this estrogen. And when you gave estrogen, she started bleeding after that. But why body was lacking estrogen? Premature ovarian failure. Suppose patient doesn't bleed even now. You have given estrogen, you have given progesterone, still no bleeding. Means problem is not hormonal. Agar hormonal hoti, it would have got corrected. Problem is of the uterus. Asherman syndrome. Problem is of the uterus, that is why she is not bleeding even after giving the hormones. So progesterone challenge pe, if she starts bleeding by progesterone only, it is anovulation. If she starts bleeding by giving estrogen and progesterone both, it is gonadal failure. If she doesn't bleed at all, it is uterine Asherman syndrome. That is how you evaluate secondary amenorrhea. Post DNC, patient developed secondary amenorrhea. Progesterone challenge test done. Estrogen and progesterone challenge test were negative. When you give estrogen, progesterone, even then it was negative. Hormone भी दे दिए तब भी negative है. So problem is not hormonal. Problem is uterine wall is scarred. ठीक है? Okay? So this finishes our primary and secondary amenorrhea. Now we come to abnormal uterine bleeding. I'll take just another hour and we will finish AUB and we will finish all the other topics like infection and everything. Okay? Going ahead with abnormal uterine bleeding. Abnormal uterine bleeding mein what do you have to know? What is normal? If you know what is normal, you will know what is abnormal. Okay? So what is normal? Remember 4 to 8. ये number याद रखना है. This is the duration of flow. Normal duration of flow happens for 4 to 8 days. अब इसी 4 में add 2 here, add 3 here. This is the normal cycle length. What is the normal cycle length? 24 to 38 days. अब इसी 4 to 8 में यार यहाँ पे 0 add कर दो. 4 to 80 ml. It is the normal volume. So duration is 4 to 8, cycle is 24 to 38, flow is this much. And there are various terminologies. If it is less than, suppose 4 नहीं exactly 5 ml है, but it can be done. If it is less than 5 ml, बहुत कम flow है, less than 5 ml, hypomenorrhea. क्या इस पे question आया है? Yes, इस पे question आया है. That is why you have to know these definition. If flow is more than 80 ml, so much flow, menorrhagia. ठीक है? If the cycle length is less than 24 days, means cycles are coming very fast, it is less than 24 days, then we call it polymenorrhea. Cycles are coming very, very fast. If cycle is more than 38 days, cycles are coming very late, it is oligomenorrhea. So these are the 4 terminologies based on this definition. Okay? If you have any questions, please keep asking on the message group. There is no problem, absolutely. Now, what are the causes? Remember palm coin? Remember palm coin is the cause? So palm is the structural cause. Polyp, adenomyosis, leiomyoma, malignancy. coin is the non-structure causes. Let's do the structure causes first. Polyp is a small endometrial growth. Polyp is small endometrial growth. And how do you diagnose this? छोटा सा uterus है, uterus के endometrium में छोटा सा growth has formed. That is polyp. How do you diagnose polyp? The diagnostic choice is hysteroscopy. Please write down the diagnostic method of choice for polyp is hysteroscopy. The treatment for polyp is polypectomy. Polypectomy is the treatment. If somebody doesn't want polypectomy, then LNG IUS. Mirena. Fibroid is a fibromuscular tumor. It is a fibromuscular benign tumor. The diagnostic method of choice for fibroid is ultrasound. And the treatment is either you can give drugs or you can do myomectomy. Either of these can be done. Adenomyosis क्या है? Adenomyosis is the pathology. Adenomyosis is the pathology where the uterine endometrium wrongly migrates to the myometrium. When the endometrium wrongly migrates to the myometrium, the uterus enlarge. इतना inflammation होता है because of this foreign body, uterus enlarge. It becomes very soft and enlarged. So it is endometrial tissue migrating to myometrium. Uterus becomes enlarged and very soft, and there is very high dysmenorrhea. Why? Because uterus is so inflamed. There is dysmenorrhea, there is chronic pelvic pain, there is dyspareunia, there is always pain. The diagnostic method for adenomyosis is MRI. Please सबके diagnostic method keep writing down. For it is MRI. The treatment of choice is hysterectomy. If patient doesn't want hysterectomy, then Mirena. Otherwise, the treatment of basic choice is hysterectomy. If this endometriosis tissue, endometrial lining tissue, instead of staying where it should, it migrates outside. The endometrial tissue migrate outside uterus. Then it is called as endometriosis, like this. Can you see these black powder brown areas? Small endometrial tissue has gone into the pelvis. And the diagnostic method of choice is laparoscopy. In laparoscopy, you can see these lesions and do the histopathology. Laparoscopy plus histopathology is diagnostic for endometriosis. Again, a very painful condition. Here also there is a lot of pain, dysmenorrhea plus dyspareunia, but there is also infertility. Adenomyosis mein there is no infertility. Endometriosis mein outside there is so much inflammation, everything gets stuck, resulting in infertility. So these are the different structural causes. This is how a polyp looks. This is endometrial growth, a polyp. Hysteroscopy of a polyp. This is, I have shown the two things. Fibroid. Can you see a localized tumor? This is fibroid. Can you see the whole enlarged uterus? Whole enlarged. The uterus is uniformly enlarged. In fibroid, uterus is non-uniformly enlarged. Only a segment. Can you see only this is the uterus. And only a segment has got enlarged. In adenomyosis, whole uterus is very uniformly enlarged. And can you see these cysts? छोटे-छोटे cysts दिख रहे हैं? These are myometrial cysts. Very characteristic of adenomyosis. ठीक है? Investigations. Whenever there is an abnormal uterine bleeding, the investigation, the first test, just like secondary amenorrhea, is always pregnancy. Whenever a patient comes to you with abnormal blood flow, abnormal menstrual cycle, the first test is always pregnancy. After that, now you start ovulating, start evaluating the cause. What do? You do the ultrasound. For any structural cause, we do the ultrasound. Another common cause is, I told you the most common cause is anovulation. So what will you do? You will check for endometrial sampling. Always check for endometrial sampling because one of the causes is hyperplasia. Endometrial hyperplasia, endometrial cancer can also cause abnormal bleeding. So anybody who is more than 40, you have to do endometrial sampling. More than 40 abnormal uterine bleeding, always do endometrial sampling using this. Pippil's curate. Pippil's curate is used a very thin pen की refill जैसा structure for endometrial aspiration. It is done in everyone who is having abnormal bleeding and age is more than 40. Also, if there are certain high risk features. High risk features कौन से? High risk features ये हैं. What are the features which are high risk for endometrial carcinoma? Whenever there is a hyperestrogenic state. Whenever the condition is hyperestrogenic, there is always a risk of endometrial cancer. जैसे PCOS, obesity, thick endometrium. Patient is not responding to your medical management, and hypertension and diabetes. They are the high risk category. And whenever there is a high risk category, you do the endometrial sampling. If it is not the high risk category, you will do endometrial sampling if the patient is more than 40 years. Okay? So endometrial sampling is very important if patient has AUB. The shown aspirator is required for endometrial sampling. A 28-year-old para-1 live-1 presents with intermenstrual bleeding since 1.5 months. What is the first investigation? First, be very careful. जैसी आंसर देखा अल्ट्रासाउंड, don't mark it. Read all the investigation, all the choices, and you will realize a better answer is there. Urine pregnancy test. ठीक है? So हो सकता है आप अल्ट्रासाउंड देखो, आपको लगे अरे यार ये this is the investigation which ma'am said, but always once you will read it, you will realize that better answer lies there only. ठीक है? According to Fmge, what is the menstrual cycle length abnormal? Write it down. 4 to 8 days was the normal duration. Cycle length was 24 to 38 days. When it is abnormal, when it is more than 38 days. ठीक है? Which of the following is not a hyperestrogenic condition? Not. हमने अभी पढ़ी थी hyperestrogenic condition. Nulliparity is, endometriosis is, tamoxifen. Tamoxifen is a selective estrogen receptor modulator which is used for breast cancer. So yes, it is estrogen receptor modulator. It increases the estrogen levels. Low BMI is not hyperestrogenic. High BMI is. Whenever BMI is high, whenever women are obese, her estrogen content is high and she is at risk of endometrial cancer. Not low BMI. A patient complains of dysmenorrhea, dyspareunia. Speculum shows bluish powder burn lesion on cervix. Nodularity is also felt. What is it? छोटे 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 powder burn areas and nodularity है, pain है. Endometriosis. Endometriosis में endometrial tissue is going outside the uterus, causing small inflammation everywhere, and sometimes it is felt as nodule. And everything is stuck. Uterus is small and immobile because इतना inflammation हो जाता है, uterus becomes immobile. 30-year-old presents with severe dysmenorrhea, dyspareunia and infertility. Diagnosis shows endometriosis. Chalo. During the procedure, there was pelvic adhesions, bowel was stuck. What is the next step? When it is so bad that the bowel is stuck and she has infertility. Okay? And cystic ovaries are stuck to each other. What will be the answer? Will you do hysterectomy and oophorectomy? Will you remove the ovaries in 30-year-old girl? She is infertile. She may be planning pregnancy. Will you do hysterectomy? No. Cystectomy. Remove the cyst of the ovaries, remove the adhesions and let her plan the pregnancy. Cystectomy and adhesiolysis. Identify the type of myoma as 4. This one. Myomas are different types depending on their location. Some which are very close to the endometrium. If I show you like this. One which are very close to the endometrium, they are submucosal. One which are lining in the wall is intramural. Mural matlab wall. In the mural, intramural is in the wall. One which is close to the periphery, to the outer area, subserosal. So most common are 3 types. Submucosal, intramural and subserosal. Most common among these 3 are Intramural. Intramural variety is most common. Now sometimes they hang by a stem. Can you see a small stem here, small stem here? When they hang by a stem, we call it pedunculated. So this is pedunculated submucosal, this is pedunculated subserosal, this is pedunculated cervical coming from cervix. This is sixth one is broad ligament fibroid. So fourth one is pedunculated submucosal. Which is the most common type? Intramural is most common. Gold standard test for endometriosis. I told you in that table. How do you diagnose endometriosis? Endometriosis में endometrial tissue is in the pelvis, outside, सब कुछ outside है. इतना छोटा tissue can you see by ultrasound or MRI? Laparoscopy. Though after laparoscopy, histopathology is to be done. So ideal answer is laparoscopy plus histo, but if they are given separate, laparoscopy is a better answer. A 36-year-old para 2 live 2 present with severe endometriosis and on laparoscopy it is pelvic adhesions. Now last question mein she was infertile, endometriosis. Here she is para 2 live 2 with severe endometriosis. What should be done in laparoscopy? TLH सिर्फ यूट्रस हटाएंगे, यूट्रस प्लस ओवरी हटाएंगे या सिर्फ ओवरी हटाएंगे? She is 36. Unless a patient is near menopause, unless patient reaches near menopause, you will not remove ovaries. You will not create menopause from your own side. Since she has severe adhesions, you will remove the uterus. But you will not remove the ovaries. In 36-year-old woman who is not even closing menopause, ovaries will not be removed. So this finishes our abnormal uterine bleeding. Now what is left is infections, pelvic organ prolapse and contraception. Okay? Cancers I will not do because it will take a lot of time. So I will send you the PDF. There the cancers के बारे में जो याद रखना है and all the questions of the cancers will be written there. You can read all the questions in that one place. All the recent 4-5 year questions. Okay? But in the meantime I have only half an hour left. We will finish infections and we will finish organ prolapse. Okay? Infections. Infections in the female genital tract can be of various places. It can be of vulva and vagina. Infection can be of vulva and vagina. जिसे हमने कहा vulvovaginitis, vulva and vagina infection. Ascent up, it can be cervicitis. Ascent more up, it can be endometritis and salpingitis. Now endometritis, salpingitis, pelvic peritonitis, इन सबको मिला के बोलते हैं PID. ये pelvic inflammation हो गया है ना. Cervicitis and vulvovaginitis are separate, but uterine lining का infection, tubes का infection, pelvic peritoneum infection, everything is called PID. So if we talk about vulvovaginitis, it is caused by 3 organisms: bacterial vaginosis, candida, trichomonas. You have to know the characteristic features and the treatment also, क्योंकि infection is something which you are expected to know, है ना, कि infection को कैसे treat करता है. Bacterial vaginosis मतलब it is not an infection. It is just the flora has changed. जो lactobacilli which is in high in number, उसकी जगह the other commensals increase in number. So it is not infection, it is just the change in the flora. So normal flora, can you see in the left side, the normal one has high lactobacilli, which are gram-positive rod-like bacilli. But in bacterial vaginosis, can you see there are no lactobacilli? I can't see lactobacilli. The other commensals like Mobilincus, Peptostreptococcus and Gardnerella, they all increase. They are small, rod-shaped, comma-shaped, gram-positive bacilli. So bacterial vaginosis is just the change in the flora. It is the most common cause of vaginal discharge. ठीक है? How do you diagnose bacterial vaginosis? 2 scores. Remember 2 scores for bacterial vaginosis: Nugent score and Amsel's criteria. These 2 are for bacterial vaginosis. Clinical है, कोई भी hi-fi test नहीं है. It's all clinical. Nugent score में you do the gram stain like here, जैसे आपने किया है, and you count the number of cells. You count the number of lactobacilli. You give them a score. Don't remember the score. Don't remember. Just remember Nugent score एक gram stain है, जिसको which we do for bacterial vaginosis. ठीक है? So it's a gram staining microscopy which we do for bacterial vaginosis. Amsel's criteria is also for bacterial vaginosis. ये आपको पता होना चाहिए. It is about how the discharge looks like. The discharge is homogeneous thin discharge, homogeneous thin grayish discharge. How it smells? Fishy. What is the pH? Alkali. And what do you see when you see the microscope? Clue cells. What is clue cells? Can you see this cell? Epithelial cells. ये vaginal epithelial cells है. Can you see how much bacteria is studded onto it? So much that you can't even see the margin. Can you delineate the margin? No. Margins are not delineated because so much bacteria is stuck on the margin. This is clue cell. Clue cell says the epithelial borders are not visible because of high number of bacteria. So Amsel's criteria is any three are present among these four. Thin grayish discharge, smells fishy. When I did the pH, it was 4.5, and when I saw under the microscope, it had clue cells. This is bacterial vaginosis. Treatment, metronidazole. Remember, it is not an infection, it is just change in the flora. It is not a sexually transmitted infection. So do you treat the partner? No. Partner treatment is not done. It is not via sexual transmission that you get bacterial vaginosis, and the treatment is metronidazole. Partner is not treated. जब है ही नहीं sexual transmission से तो why to treat partner? Second, trichomonas caused by Trichomonas vaginalis. It is a sexually transmitted infection. Trichomonas is a non-viral STI. How the discharge is? Greenish frothy discharge. Also strawberry cervix. ठीक है? How do you diagnose? When you do the microscopy, bacterial vaginosis के microscopy में what did you saw? Clue cells. Here what did you saw? You saw the motile trichomonas. Can you see flagellated motile trichomonas? Can you see? They look very similar to leukocytes. But how can you differentiate? Trichomonas have jerky movement. So because of movement you can differentiate. So you can see motile organisms in trichomoniasis. What is the treatment? You can also culture it. You can also see trichomonas on pap smear. But the diagnostic is microscopy. And the treatment is again metronidazole. Just like bacterial vaginosis, metronidazole. But will you treat the partner? Will you treat the partner? Yes. It's a sexually transmitted infection. Why will I not treat the partner? Patient has got it from the partner. So I will treat the partner. Candidiasis, fungal infection. One very characteristic is excessive inflammation. Can you see excessive redness? Bacterial vaginosis and trichomonas also have mild irritation, mild itching. But here it is swelling, redness, very excessive pruritus and pain. Every pruritus and pain is excessive. And the discharge is very curdy, cheesy, curdy discharge. How do you diagnose? Same microscopy. You do microscopy, what do you see? Budding cells. Can you see these budding yeast cells? What were you seeing in bacterial vaginosis? Clue cells. What were you seeing in trichomonas? Motile organisms. What are you seeing in candidiasis? Budding cells. Okay? What is the treatment? An antifungal cream, clotrimazole or miconazole. Also you can give oral fluconazole. Single dose. Okay? Partner treatment, it is not done. Again, candidiasis is not a sexually transmitted infection, so you will not treat the partner here. Now questions. The Amsel criteria is used to diagnose which of the following? Amsel criteria. Vaginosis. Patient present with curd-like discharge and there is pseudohyphae. Candidiasis. Women present with greenish frothy discharge. There is erythema and saline microscopy show motile organisms. What is the diagnosis? Trichomonas. So all these are vulvovaginitis with different presentation. Okay? Now question on treatment. 27-year-old women present with malodorous discharge. On examination, the whiff test is positive. Oh yes. Gram stains show clue cells. What is whiff test? I told you, remember the fishy odor of bacterial vaginosis? Sometimes there is no fishy odor. When you smell the discharge, the odor is not fishy. But when you add KOH, When you add QH, there is a lot of fishy odor. This is whiff test. On adding QH, the fishy odor starts coming. This is bacterial vaginosis whiff test. So this is bacterial vaginosis. There are also clue cells. What is the treatment now? Simple. Okay? Cervicitis. Now, this was vulvovaginitis caused by 3 organisms: bacterial vaginosis, trichomonas, and candida. Cervicitis is caused only by 2 organisms: Neisseria, gonorrhea, and chlamydia. They both are sexually transmitted infections. It is the most common bacterial STI. Most common. How do you know it is cervicitis? Patient will come with discharge. How will you know it is vaginitis or cervicitis? There will be discharge coming from cervix. And when you introduce a swab, there will be bleeding. So either discharge coming from cervix or a swab inserted in cervix will start bleeding. It indicates cervicitis. Causative organisms are 2. Okay? How do you treat these causative organisms and what is the diagnosis for these 2? Nucleic acid amplification test. It is not simple like vulvovaginitis. Gonorrhea can be those seen on gram staining. It is gram-negative diplococci, intracellular. Can you see intracellular diplococci? Gram-negative intracellular diplococci is gonorrhea. They both are sexually transmitted. So will you treat the partner? Yes. What is the treatment for gonorrhea? The treatment is ceftriaxone. And for chlamydia, the treatment is doxycycline. Important question. In pregnancy, can I give ceftriaxone in pregnancy? Yes. Can I give doxycycline in pregnancy? No. So treatment of chlamydia in pregnancy, azithromycin. Okay? Okay? So here male and female are both treated. Now condition where both male and female partner are treated. In candida, do we treat the partner? I told you it is not an STI. In bacterial vaginosis, do we treat the partner? Trichomonas we treat the partner. We treat the partner in trichomonas, we treat it in chlamydia, we treat it in gonorrhea. Genital warts caused by HPV, low risk HPV. 90% of warts are caused by HPV 6 and 11. 10% are caused by high risk HPV. So high risk HPV can also cause warts. Diagnosis is by visibility. It is visible. There are painless lesions. Okay? What is the treatment? Treatment can be of 2 types. Patient can administer some treatment by himself. Imiquimod, podophylox or simicachicans. They are the treatment that patient can apply himself herself. Some treatment is to be given by the clinician. Trichloroacetic acid. Cryotherapy, surgical removal using laser or scissor. Question comes, what is the treatment of choice when it is very close to the important structures or when the patient is pregnant? That the treatment comes. That's the question comes. The treatment of choice of warts in pregnancy or when it is close to urethra, then you can't apply these chemicals. So the treatment of choice in pregnancy is these 3. Either trichloroacetic acid or removal by a laser or cryo. Among these 3, the treatment of choice is for pregnancy is cryo. Cryo has the best healing rate and the minimal complications rate. So what can we use when patient is pregnant with warts? We can use trichloroacetic acid, we can use laser, we can use cryo. Among them the best is cryo. Can we use imiquimod or podophylox? No. In pregnancy we can't. Okay? So there was an image of a pregnant woman with warts. What will you do? Cryo. Done? Now we come to genital tuberculosis. Genital tuberculosis always comes from lungs. We'll be finishing in 20-25 minutes now. It always comes from lungs. Okay? Where does it affect? The first structure in pelvis which is affected is tubes. And tubes also, the part which is affected is ampulla. Important. The part of tube that is affected is ampulla. It leads to fibrosis and damage of the tubes. and then it travels to the uterus. So when TB travels to the uterus, what it causes? It damages the decidua. As a result, Asherman syndrome, where there is amenorrhea. Asherman syndrome happen, patient stops bleeding. So this is the tubal changes. On HSG, can you see the beaded appearance? Smooth tubes turn into beads because of scarring. Because of scarring, it is beaded appearance. Hydrosalpinx. The fimbria are blocked. Then the fimbria are blocked. That is why the tubes are swollen. Hydrosalpinx. Can you see tobacco pouch? Fimbria is blocked. That is why जो spill होता है dye, when you are injecting dye, there should be a peritoneal spill. That is not there. It is blocked, so tube dye is getting collected in the terminal end. It is the tobacco pouch appearance. A girl with history of low grade fever, weight loss and pain and amenorrhea. So amenorrhea के साथ उसको fever and weight loss भी है. Now I am thinking not ovarian dysgenesis, maybe not some central cause, something systemic. On examination, pelvic mass is felt and also there is ascites. So many general symptoms are present. Is it fibroid? Fibroid will not cause amenorrhea. Is it malignancy in 18-year-old girl? Malignancy, that too with fever? Ectopic pregnancy? No, it is genital tuberculosis. Even if I don't know the answer, then also by exclusion I can notice genital tuberculosis. On basis of image, what is your diagnosis? It is cornual block. Cornual block में this part is block. How do you see cornual block? आपको बस you can see only the uterus, not the tubes at all. That is the cornual block. It is hydrosalpinx. Which part of fallopian tube is involved in genital TB? Ampulla. So these all are the PYQs which I am doing basically in theory. I am discussing only that part that has been asked multiple times. Lady present with history of lower abdominal pain and restricted movement. Laparoscopy show pus at the fimbria. Means such an infection. Is it salpingitis? Yes. Do we call salpingitis also PID? Yes. Okay? So it is PID. Clear? Now, Bartholin gland abscess. Where is Bartholin gland present? The Bartholin gland is present in the posterior 1/3, just at the level of introitus, just at the opening. The function is secretion of the alkaline fluid during the process of consummation, during the process of sexual activity. It provides the lubrication. So it is present just at the posterior 1/3. This is anterior urethra. So just at the posterior 1/3, just inner to the labia minora. This is the place, Bartholin gland. Now sometimes when the gland is obstructed, it leads to Bartholin cyst. And when it gets infected, it leads to Bartholin abscess. Bartholin cyst is not infected. It is just the collection of fluid. The treatment is marsupialization. It has been asked many times in NEET PG, so it can be asked here. Marsupialization मतलब cyst में you make a cut and you evert the edges. उसको आप evert कर देते हो so that it doesn't form again. इसे कहते हैं marsupialization. But abscess is infection. So here you need to drain the pus. You need to drain the pus and start with antibiotics. So here the treatment is different. ठीक है? Marsupialization is the ideal treatment of choice for condition X, which is Bartholin gland. Because it's a gland. If you just make a cut, leave it, cyst will form again. So you make a cut and you evert the edges. Okay, that has been asked in the question. Remember the position of Bartholin gland, how it presents. It is a painful swelling that patient will have difficulty in walking and it will be very tender labia. And how the treatment is done. Okay? Now a little bit about, I think we are running out of time. So let's go to the infertility is still easy. What is not easy is, what I think is easy is, yes, fistulas and prolapse and all those things. Pelvic organ prolapse. That is something which I want you to teach because I think people really miss on that. Starting with incontinence. A woman experienced leakage of urine during exercise. During stress. जैसे ही stress पड़ा, it leaked. What is it? Stress incontinence. Stress incontinence is the most common form of incontinence. It is due to sphincter weakness, levator ani and sphincter weakness. What is urge incontinence? Urgency. Patient wants to urinate and can't postpone it. Suppose the toilet is closed, patient can't postpone it. So there is so much urge. Sphincter is normal, but patient is not able to hold it. That is urge incontinence, and that is due to detrusor. Detrusor is the bladder muscle. That is due to detrusor overactivity. Neurogenic incontinence is rare, happen in patient of diabetes mellitus or spinal cord injuries. Okay, that is the neuronal one. Now, fistulas. Genital fistulas. Fistulas matlab abnormal connection. Two organs which were not supposed to get connected, they get abnormally connected. That is the fistulas. Now, that can be vesico-uterine, between bladder and the uterus. So, this is the bladder and this is the uterus. Now, fistulas can form at any level. Vesico-uterine is the fistula has formed at the bladder and uterus. This is a vesico-uterine fistula. Vesico-vaginal, between the bladder and the vagina. Vesico-vaginal fistula is the most common fistula that is formed during the delivery. When a woman delivers and the head is stuck in the vagina for long, head is stuck in vagina, that leads to the necrosis of vaginal wall, resulting in vesico-vaginal fistula. It is one of the most common fistulas seen after delivery. Yes, you will get the PDF, beta. I will upload the PDF here only. Don't worry. I want you to read the PDF by today or tomorrow. Okay? Urethrovaginal fistula is between urethra and vagina. Uretrovaginal fistula is between when the ureter is coming. Here the ureter is coming. So uretrovaginal is between the ureter and vagina. And uretrovaginal fistula is formed during the gynecological surgeries. आप सर्जरी कर रहे थे and you did some wrong incision during gynecological surgery, uretrovaginal is formed. During the deliveries, vesicovaginal is formed. ठीक है? What is the most common cause of fistula? In India, if it is asked in your country, it is obstructed labor. In outer countries, in world, the most common cause is surgeries, gynecological surgeries. So what is the most common cause of fistula in our country? Deliveries. So what is the most common fistula in our country? Vesicovaginal. What is the most common fistula in western countries? Uretrovaginal. क्योंकि सर्जरी से uretrovaginal बनता है. ठीक है? Okay? What is the hysterectomy? That is the most common cause. The most risky hysterectomy that can lead to fistula. Most risky surgical cause में the most risky hysterectomy is radical, which is done in cancers. But the most common cause, the most common hysterectomy as such is simple. Simple hysterectomy बहुत risky नहीं है, लेकिन वो इतनी ज़्यादा होती है. It is done so much that the most common reason for surgical fistula is simple hysterectomy. Surgical fistula का most common reason है simple hysterectomy. But the most risky hysterectomy is radical. That is the most risky one. The safest hysterectomy is for fistulas. The safest that will never lead to fistula formation is vaginal hysterectomy. Vaginal hysterectomy में कभी fistula नहीं बनता. ठीक है? Now, how to diagnose the fistulas? First of all, कुछ तो clinical symptoms. ठीक है? If I just make a diagram here. Vesicovaginal, ठीक है, ये vesicovaginal है. Urethrovaginal, the common fistulas, and ureterovaginal. How the scenario will be given to you, how the patient will present. Leakage कब होता है? Vesicovaginal में whatever urine is in bladder, it is constantly leaking into vagina. So leakage is continuous. In uretrovaginal also, whatever urine is there in the ureter constantly coming, it is constantly coming into the vagina. So leakage is continuous. Uretrovaginal में urethra में urine नहीं होता है. Urine is not there in urethra. Urethra में urine comes when the patient is peeing. When the patient is passing urine, then the urethra opens, then the urine comes in urethra. So urethrovaginal fistula may the leakage happen when the patient is passing urine. As such, there is no leakage. She will tell you, when I pass urine, urine comes from urethra and urine comes from vagina also. Whereas vesicovaginal और uretrovaginal में continuously leakage हो रहा है. Urethrovaginal में leakage सिर्फ when she is passing urine तब हो रहा है. And does she pass urine? What about a normal urination? Since vesicovaginal में bladder is not getting filled, जितना भी bladder में urine is getting collected, it is continuously leaking. Bladder is empty. It is not getting filled at all. She doesn't pass urine. She is continuously leaking urine from vagina and she is not passing urine. Uretrovaginal में one ureter is draining the fluid, draining the urine continuously into vagina. So there is continuous leakage. But bladder is getting filled. There is another ureter also. Bladder is getting filled. She will pass her own urine also. What about urethrovaginal mein? She will pass urine also, and while she pass urine, the urine will leak. These are the three scenarios. Then, so question can come as clinical scenario. Now, 3 swab test. जिस पे question आया है. This is one of the way to diagnose the fistulas. In 3 swab tests, you insert 3 cotton swabs into the vagina and you fill the bladder with methylene blue. Now, when it starts leaking, how will it stain the cotton swabs? If the lowermost cotton is stained blue, it is stained blue, lowermost, it is coming from urethra. Upper wale are not stained. If the lower one is stained, it is from urethra. If the middle one is stained, lower one will also get stained. Eventually, lower one will also get stained. So, if the lower 2 are stained, it is coming from bladder. Bladder has filled blue dye. If the cottons are getting wet but not stained, like the upper one, it is wet but not stained. So, where urine is coming from? Urine is coming from a place where the dye has not reached, ureter. So, when the question is coming to you that, when the question is coming that the cotton is wet but it is not stained blue, it is ureter. ठीक है? ठीक है? A patient with history of difficult labor and cesarean present with dribbling of urine through vagina on 7 days. Dribble हो रहा है after labor. It is vesicovaginal fistula. ठीक है? Identify the fistula, bladder and vagina, vesicovaginal. Highest incidence of ureteric injury is seen in highest incidence. सबसे ज़्यादा किस में मिलती है? Radical hysterectomy. Radical मतलब Verdheim's hysterectomy. A woman complains of involuntary urine voiding during workout. When she work out, urine leaks. जब भी stress पड़ा, urine leak हो गया. It is stress incontinence. This was about fistulas. Methylene blue test पता होना चाहिए. Sites of fistula and the causes of, most common causes of formation of fistula. Now come the prolapse. Prolapse treatment, please all of you be very clear when I ask prolapse. Tell you, many questions have been asked on prolapse treatment. So many. This is the last topic that we are discussing. Now prolapse can be, there are different types. It can be anterior wall prolapse. When the anterior wall prolapse, it will bring the bladder also with itself. When the posterior wall prolapse, it will bring the rectum with itself. So there can be different areas of prolapse. Anterior prolapse. Anterior prolapse को हम कहते हैं either cystocele or urethrocoele. What is the treatment? It is called as anterior colporrhaphy. Colpo मतलब vaginal wall. Colporrhaphy मतलब tightness. This wall is weak. You just repair, open the wall, push the content behind and tighten the wall. इसे हम कहते हैं anterior colporrhaphy. When it is posterior wall prolapse, it is known by the name of rectocele. Rectum also comes. It is not enterocele. Enterocele तो bowel है यहाँ पे. This bowel comes through pouch of Douglas यहाँ पे. It is not posterior wall. Posterior wall is this one. Whenever there is a posterior wall weakness, this is the posterior wall. This is the posterior wall. Pouch of Douglas is not posterior wall. सो एंटेरोसील इज नॉट पोस्टीरियर वॉल प्रोलैप्स. ठीक है, क्वेश्चन आता है, डोंट राइट डाउन पोस्टीरियर वॉल प्रोलैप्स. पोस्टीरियर वॉल प्रोलैप्स इज रेक्टोसील और उसका ट्रीटमेंट है पोस्टीरियर कॉल्पोग्राफी. सो पोस्टीरियर कॉल्पोग्राफी इज डन फॉर रेक्टोसील, नॉट फॉर एंटेरोसील. तो फिर एंटेरोसील, व्हाट इज एंटेरोसील देन? अब आते हैं अपाइकल प्रोलैप्स. द प्रोलैप्स इज फ्रॉम एपेक्स. It can be two types. The whole uterus is prolapsing, the uterine prolapse, and it can be enterocele. The pouch of Douglas is prolapsed. When it is uterine prolapse, it is uterine prolapse. It is enterocele, means small bowel is coming. It is apical prolapse. Enterocele का repair क्या है? It is coming because of the weakness of pouch of Douglas. ना, pouch of Douglas की weakness की वजह से. What do we call pouch of Douglas? Cul-de-sac. So repair the cul-de-sac, culdoplasty, named by the scientist McCall culdoplasty. Repair the pouch of Douglas, McCall culdoplasty. Enterocele का repair is not posterior colporrhaphy. That's what I want to tell you. It is McCall culdoplasty. What about uterine prolapse? अब आती है बारी uterine prolapse की. Uterine prolapse का main treatment है remove it, hysterectomy. But what if it has happened in a young age girl? So uterine prolapse का treatment is not that easy. Uterine prolapse, if the family is complete, then you will do hysterectomy. But if the family is not complete, family is incomplete, then you can't remove uterus. Then you do sling surgery. You just hang the uterus. स्लिंग सर्जरीज बहुत सारे तरह की होती हैं. द बेस्ट इज सेक्रो हिस्टेरोपेक्सी. व्हाट आर यू डूइंग? यू आर हैंगिंग, कनेक्टिंग द हिस्टेरो यानी यूट्रस टू द सेक्रम वाया मैश. सेक्रो हिस्टेरोपेक्सी. इट इज डन व्हेन पेशेंट हैज नॉट कंप्लीटेड द फैमिली. सेक्रो हिस्टेरोपेक्सी और यूट्राइन स्लिंग ऑपरेशन. Suppose it's a very old, fragile woman. She can't tolerate any surgery, very old. We don't have many options. What will you do? Leafort. Leafort में you just stitch the vagina, stitch the labia, nothing will come out. Quickly done, safe. Leafort. Leafort is done in very old, fragile patients. ठीक है? अब तीसरी कंडीशन आती है. This was prolapse. Prolapse is when the whole uterus is coming down. Whole uterus is from its normal position थी uterus की ये and it has come down. एक problem होती है cervical elongation where the fornix become very deep. Here the fornix are not deep. They are of same length. The fornix become deep because of cervical elongation. It is present in very young girls. It looks like prolapse but it is cervical elongation. Cervical elongation का treatment है Fothergill. Fothergill or Manchester operation. That is not done for uterine prolapse. It is done for cervical elongation. You amputate the cervix and tie it with the surrounding ligaments. It is modified Fothergill or Manchester operation. इसीलिए I wanted to teach you prolapse. Anterior prolapse में anterior colporrhaphy, posterior wall में posterior colporrhaphy, apical में enterocele है तो McCall culdoplasty, uterus है तो hysterectomy. बट अगर फैमिली इनकम्प्लीट है तो सेक्रोहिस्टेरोपेक्सी. बहुत ओल्ड वुमेन है तो लीफोट ऑपरेशन. एंड अगर सर्वाइकल एलोंगेशन है देन फॉदरगिल ऑपरेशन. ठीक है? मैकेल कल्डोप्लास्टी इज डन फॉर कल्डोप्लास्टी. आई एम रिपेयरिंग द cul-de-sac, the pouch of Douglas. I am doing enterocele repair. What is the best treatment in case of vault prolapse with cystocele and rectocele? Cystocele मतलब anterior wall भी गया, rectocele मतलब posterior wall भी गया. What will we do? Anterior and posterior colporrhaphy. है ना? What procedure is performed on nulliparous women with uterine prolapse? Nulliparous with uterine prolapse. What will you do? Sacrohysteropexy. 75 women with mass coming per vaginum. During pre-anesthetic checkup, she was very unfit for major surgery. Very unfit. Leafoots. ठीक है? Nulli gravida, no cystocele, no rectocele, but a third degree prolapse. अगर फर्स्ट डिग्री प्रोलैप्स होता तो यानी वेरी अर्ली प्रोलैप्स, तो हम क्या करते, pessary, then we would have inserted pessary, but it is a third degree prolapse, nulli gravida. What will I do? I'll do abdominal sink surgery. I'll not do Fothergill. Fothergill is for elongation. It is prolapse. POPQ classification for prolapse आपको कैसे करना है ये जानने की जरूरत नहीं, but there is a grid which is made. A grid which is made to show how much the prolapse has happened, and we give points A, B ऐसे करके. These points are in respect to the hymen. Hymen से कितना ऊपर, hymen से कितना नीचे. ठीक है? That's it. So we finished the today's class. Rest left is contraception and cancer. Not many questions have been asked from both of them. ठीक है? So I have written the PDF. I'll post the PDF. Please read that, and that will finish your gynecology. We have finished 70%, just 30%. In fact, we have finished 80%. 20% is left because of time. That you can cover through the PDF. So read the PDF either today night or tomorrow. Don't give so much time. Everything will go away either ways. ठीक है? So what I can say is just be very focused. Very few days are left, so just give maximum of what you have, whatever energy you have, put it, revise. Don't read anything new. Do not read. जो पढ़ा है उसको बस रिवाइज करो. आपको लगता है 20% कोर्स इज स्टिल लेफ्ट, 30% कोर्स इज स्टिल लेफ्ट, रहने दो. इफ इट इज लेफ्ट, लेट इट बी लेफ्ट. जस्ट रिवाइज वॉट एवर यू हैव रेड, वॉट एवर. डोंट रीड एनीथिंग न्यू. जो पढ़ा है उसको बस just try to just memorize it for very long time. ठीक है? Everything will be good. Thank you so much everybody, and